It is my honor to introduce the lady of a group. Dr. Ljiljana Marina is an MD PhD and works as an endocrinologist at the National Center for Infertility and Endocrinology of Gender at the University Clinical Center of Serbia. She works in the field of adrenal gland and reproductive endocrinology. As a co-chair of ESE Young Endocrinologists and Scientists for the last 2 years, Dr. Marina founded the ESE newsletter and the ESE observership programs and was a member of the Executive Committee of the European Society of Endocrinology. She is one of the co-authors of the latest ESE guidelines on adrenal incidentalomas. From 2021, she leads the Working Group 5 COST Action Harmonization 21. I think it's 2022. In 2022, she was awarded the European Society of Endocrinology Special Recognition Award. And in 2024, Dr. Marina has been elected as an EJE Rising Star. She is member of the clinical committee within the European Society of Endocrinology and a member of the Serbian Medical Society and the Serbian Society for Menopause. Ljiljana, the floor is yours.
Eleni, thank you so much for this nice introduction, and congratulations to both you and Christina on what seems an excellent symposium already. And it is my great pleasure to be among the gentlemen of this evening talking about male infertility, and congratulations to all for the amazing talks that you already had. Daniela, thank you for the nice overview. My agenda today, as you have mentioned, will be about DNA fragmentation. So we will define it, and then we'll talk about a bit about the clinical significance and why do we test for sperm DNA fragmentation and who do we test. And we will cover a bit of the treatment and then the take-home messages. I have no conflict of interest to declare. So as Daniela have shared and explained thoroughly, the standard sperm analysis does not provide everything we need. About 15% of infertile men have normal semen parameters. And one of the problems is about the reference values, which are not entirely equivalent to the fertility assessment. So what we need is something else, which is not included in the standardized semen analysis. And it is regarding the sperm chromatin, which is exceptionally vulnerable to damage, as translational and transcriptional silencing occurs during spermiogenesis, and this limits chromatin repair mechanisms. Furthermore, the misfolding of DNA supercoiling structures in the chromosome due to twisting tensions generated by the double-stranded DNA helix can also lead to aberrant DNA repair, causing sperm DNA fragmentation or abnormalities in the chromatin structures. So as we have said, this analysis is not included into a standard sperm analysis, and there are 3 types of chromatin damage. So one is DNA fragmentation, one is abnormal chromatin compaction, and the third is chromosomal aberrations. Why is it important? Because the sperm DNA fragmentation has impacts on fertilization, on embryonic development, and on paternal genetic information transmission during both spontaneous and pregnancies after assisted reproductive techniques. SDF is primarily induced by defective maturation and abortive apoptosis, which occurs within the testes, but then later on, posticular by oxidative stress throughout the male reproductive tract, or by extrinsic factors such as heat exposure, smoking, obesity, environmental pollutants, and chemotherapeutics. We already know that patients who are infertile have much more higher sperm DNA fragmentation than the patients who are not infertile. And this is why SDF has been identified as a major contributor to male infertility, as well as to poor outcomes following ART, including impaired embryo development, miscarriage, recurrent pregnancy loss, and birth defects. So how do we measure it? We measure it by measuring actually the DNA fragmentation index. And this index is also called the DFI. It is considered a crucial indicator in evaluating semen quality, but its clinical significance in predicting the prognostic outcomes of ART and pregnancy success is still uncertain. How do we measure it? There are several assays available to assess sperm DNA damage, and most utilized tests include tunnel SCD, the one that we use, SCSA, and single-cell gel electrophoresis assay. Cutoff values vary depending on the technique and the population study. And while there is no single specific cutoff value that we are all unanimously that we agree upon, a threshold of 20% is believed to be the best value to discriminate accuracy between fertile and infertile men. So as I mentioned, there is a lot of debate on the significance of DFI. So no studies have unequivocally and directly tested the impact of sperm DNA damage on the clinical management of infertile couples. It has been suggested that the current methods for assessing sperm DNA integrity still do not reliably predict treatment outcomes from ART, and there is controversy whether to recommend them routinely for clinical use. What is interesting is that testicular sperm is reported to have lower levels of sperm DNA fragmentation when compared to ejaculated sperm. And this is why it is advised that it is combined TESA with ESE, and it may have more better outcomes than with ejaculated sperm in men with high sperm DNA fragmentation. However, what we need to communicate with our patient is that ART procedures such as ESE may exert negative effects on the genetic and epigenetic health of offspring. About 1 million children is conceived through ART, and they are born each year, and ESE is becoming increasingly common, now accounting for over 70% of all treatment. It is therefore essential that the relationship between sperm chromatin and the long-term effects of ART is explicated. When it comes to recommendations on who to screen and how to utilize DFI in the clinical setting, in the last couple of years, several major European and American societies have published their guidelines. And we will go through three major. These are the European Association of Urology, which was published this year, ESE, European Society of Human Reproduction and Embryology, and American Society of Reproductive Medicine, published 3 years ago. So the European Association of Urology has summarized the evidence on SDF and said that it is associated with reduced pregnancy rates via natural conception or intrauterine insemination, poor assisted reproductive techniques, outcomes, recurrent pregnancy loss, and unexplained infertility. And they have graded this summary as 2A. When it comes to what they are recommending is that all patients with recurrent pregnancy loss should be tested for DFI, and this strength rating is strong. Also, the patients with unexplained infertility. When it comes to varicocele, there is a weak rating, but they say that varicocelectomy may be considered in men with raised DNA fragmentation with otherwise unexplained infertility or who have suffered from failed of ARTs, including recurrent pregnancy loss, failure of embryogenesis, and implantation. And they conclude that although definitive conclusions cannot be drawn, given the heterogeneity of the studies, increased sperm DNA damage is associated with pregnancy failure. American Society for Reproductive Medicine does not recommend DNA fragmentation testing in the initial evaluation of the infertile couple. They also recommend it for the couples with recurrent pregnancy loss, along with karyotype. When it comes to ESE and the guideline published 2 years ago, This is a conditional recommendation, also to test it in patients with recurrent pregnancy loss. And when it comes to a guideline, again, ESE on unexplained infertility, they are against testing DFI in patients who otherwise have normal semen analysis according to WHO criteria. So what is a recurrent pregnancy loss? So first, let's define pregnancy. Believe it or not, this has become very complicated in the last couple of years, and there is also a term which is marked as successful pregnancy. So pregnancy, both after spontaneous conception and after ART treatments, in the definition is confirmed at least by either serum or urine beta HCG. Now, pregnancy loss or miscarriage is defined as a spontaneous demise of a pregnancy before the fetus reaches viability. This is important, and that's that the terminology used for pregnancy loss needs to be clear, consistent, and patient-sensitive. The term therefore includes all pregnancy losses from the time of conception until 24 weeks of gestation. It can also be termed according to when it happened exactly during pregnancy, such as early embryo loss, first trimester pregnancy loss, and second trimester pregnancy loss. Recurrent pregnancy loss is defined as the loss of 2 or more pregnancy, and recurrent early pregnancy loss is defined as the loss of 2 or more pregnancies before 10 weeks of gestational age. The terms spontaneous abortion, chemical pregnancy, and blighted ovum are ambiguous and should be avoided, and this is why. Every miscarriage matters. Our patients who experience a chemical pregnancy feel that the term minimizes or dismisses the reality of their experience. While a chemical pregnancy refers to an early miscarriage that occurs very soon after implantation, often before an ultrasound can detect a gestational sac, for the woman involved, it can still feel like a profound loss. For many, even a brief pregnancy, regardless of its early stage, can come with emotional investment, hope, and excitement. When the term chemical pregnancy is used, some women feel it does not acknowledge the significance of the experience, and the word chemical can make the loss sound more like a clinical detached event rather than a personal and emotional one. Instead of focusing on the term itself, many prefer to talk about it as an early miscarriage or even just a pregnancy loss, as these terms more directly acknowledge the emotional and physical aspects of the experience without framing it as a lesser or less valid form of pregnancy. By putting it this way, we can communicate that it's not necessarily about semantics, but about honoring the emotional and physical experience of women who have gone through this type of loss, and acknowledging that their grief and experience does matter. And also, this goes for men as well. They suffer too. We are far from perfect beings when it comes to reproduction. Miscarriage is relatively common, and risk varies based on factors such as age, health, and lifestyle. And you can see here that even when we are perfectly healthy and young, we still have the miscarriage rate about 11%. And then for women after 35 years of age, which now consists more than 50% of my infertility outpatient clinic, the miscarriage rate is about 25–30%. And if you are older than 40, it's about 51%. Now, recurrent pregnancy loss is less prevalent. It affects approximately 1 to 2% of women. It is less prevalent, but it is not a small number. So when it comes to treatment, it is recommended that a clinician advise male partners of couples with recurrent pregnancy loss of the connections with what damages the DNA in the sperm, and to change the unhealthy lifestyles. Evidence do show that lifestyle modifications such as cessation of smoking, normal body weight, limited alcohol consumption, physical activity could improve the clinical outcomes of couples experiencing recurrent pregnancy loss. One of the treatments that is very frequent and is talked about a lot in the past couple of years is oral antioxidant treatment, and is most common in endocrinological office when it comes to male infertility. And recently, some 2 years ago, a very thorough meta-analysis was performed, and it says that antioxidant supplementation taken by subfertile males of a couple attending a fertility clinic may increase the chance of a live birth. However, the overall certainty of evidence was very low, but this low certainty evidence suggests that clinical pregnancy rates may increase if you do use antioxidant supplementation. Subfertile couples should be advised that overall, the current evidence is inconclusive due to the poor reporting of methods, failure to report on live birth and clinical pregnancy rate, imprecision due to low event rates, high number of dropouts, and small study group sizes. Large, well-designed, randomized, placebo-controlled trials studying infertile men and reporting on pregnancy and live births are still required to clarify the exact role of antioxidants. To summarize, sperm DNA integrity is crucial for fertilization and development of healthy offspring. SDF results from defective maturation, abortive apoptosis, and oxidative stress, and can be induced by several disease states and lifestyle and environmental exposures. Evidence indicates that DFI testing is most beneficial in patients with unexplained and idiopathic infertility, recurrent pregnancy loss, varicocele, ART, in those with lifestyle and environmental risk factors. However, current guidelines do not recommend routine DFI measurement and are recognizing recurrent pregnancy loss, and some guidelines also unexplained infertility as the latest guidelines, which is very important, as the only indications for DFI measurement. High DFI can be treated by antioxidant treatment, lifestyle modification, varicocelectomy, and the use of advanced sperm selection techniques or testicular sperm for ESE, and further studies of adequate power and control design are necessary to enhance our understanding of the clinical utility of DFI. This is our National Center for Infertility Endocrinology of Gender, and which is led by Professor Svetlana Vujovic, a pioneer in reproductive endocrinology. And I want to say special thank you to our urologist, Dr. Veljko Pantovic, who made all of our evaluation and the patient evaluation much more, it makes all of that makes much more sense than before we had him. And these are the babies and the team that I'm privileged to work with every day. Thank you for your attention.